HB is an 88-day-old female weighing 3.56 kilos with no known allergies and a full code. The patient has a significant history of a prenatal diagnosis of complete heart block, secondary to maternal Sjogren's syndrome, with the patient having Sjogren's antibodies. HB was born on 3/27 at 34 and 1 via C-section due to premature labor and concern for placental abruption. The patient was immediately transferred to the PICU for a native heart rate of 60 beats per minute with third-degree AV block. On 4/2, the patient went to the OR for a permanent pacemaker, but it was unsuccessful due to her size. At this time, temporary epicardial wires were placed, and the patient was transferred to the PICU for further management and to grow prior to permanent pacemaker placement. She has a history of thrombocytopenia for which she has received 4 platelet transfusions, a history of anemia for which she has received 2 PRBC transfusions, and neutropenia. Per HEMONC, all of these cytopenias are known to occur with maternal Sjogren's syndrome. HB remained in the PICU for 77 days and went to the OR on 6/18 at 84 days old for permanent pacemaker placement. Today she is post-op day 3. HB tolerated the procedure well. She is receiving morphine and Tylenol as needed for pain. She returned to the PICU intubated but was weaned and was extubated to high-flow nasal cannula on 6/19. She was weaned to room air yesterday on 6/21, post-op day 2. Her arterial blood gases have remained stable, showing good oxygenation and ventilation. X-ray shows right upper lung atelectasis, which is thought to have been caused by compression from her chest tube. She is receiving CPT Q6 hours. Her respiratory rate was in the 30s to 60s overnight. Pulse ox was 94 to 100%. HB has remained cardiovascularly stable the past 24 hours. Her internal pacemaker is set to DDD mode with a minimum atrial rate of 80, maximum rate of 220, and a sensitivity of 10. Overnight, her heart rate was 120s to 160s. Her temperature ranged from 97.3 to 97.8. Blood pressures were 90s to 1 teens over 50s to 60s. Her magnesium was low this morning at 1.5, so she received a replacement of 25 milligrams per kilogram. Her Lasix last night was held for the patient being net 200 negative, and her fluid balance goal is even to negative 50. Because of this, her Lasix was changed from BID to daily. Her chest tube output was minimal overnight, putting out a total of 5 mLs. Post-operatively, we restarted feeds via her NG tube. However, the patient developed fussiness and had emesis, ×3. A KUB showed a small ileus. She is on maintenance IV fluids and is on continuous feeds of 5 cc's per hour through her NG tube. On examination this morning, the patient was active with a strong cry. HENT, her anterior fontanelle is soft and flat, posterior fontanelle is closed. Her mucous membranes are moist. Pupils are 3s, equal round, and reactive to light. Cardiovascular, she has strong 2+ pulses throughout. She is pink and warm with capillary refill of less than 3 seconds throughout. She has a normal heart rate and rhythm. S1 and S2 are normal. She has a midsternal dressing from her sternotomy, which is clean, dry, and intact with the midsternal chest tube, which is in place. Respiratory, she is breathing comfortably and has clear bilateral breath sounds. She has no increased work of breathing. GI, her abdomen is soft and round with no distension, however there is tenderness on palpation. Bowel sounds are normal. She has a right near NG at 22 centimeters. She is being fed Neosure 24 kcal at 5 cc's per hour continuously. She has a dressing on her left upper quadrant of her abdomen from the pacemaker placement. Pacemaker is palpated in the epigastric abdomen. Musculoskeletal, she has normal range of motion and good tone. Neurologically, she is alert and responsive. Her skin is warm and dry with normal turgor. Line, she has a right femoral art line, a left foot PIV, and a left subclavian double lumen PIC line. The patient's problem list includes health maintenance, abnormal newborn screen, anemia of prematurity, neutropenia, thrombocytopenia, congenital third-degree heart block, irregular heart rhythm, long QT interval, permanent pacemaker placement, and irritability and emesis post-feeds. Differential diagnosis for the patient includes complete heart block, ileus, and narcotic-induced constipation. My impression is that this is an 88-day-old female weighing 3.56 kilos, diagnosed prenatally with complete heart block. She is post-op day 3 for a permanent pacemaker placement. She has a post-op ileus. My plan for her is as follows. Neuro, we're going to continue morphine, Q0.05 mg per kg of morphine, Q3 PRN, and 10 mg per kg of Tylenol, Q6 PRN. We will follow her pain signs and symptoms and titrate analgesia as needed. Now that the patient has received her permanent pacemaker, we have put in a consult for PT-OT. At discharge, the patient will get a referral to the neurodevelopmental clinic. Cardiovascular, we'll monitor her heart rate and blood pressure as well as clinical signs of adequate cardiac output. We will continue with her continuous bedside cardiac monitoring. Her goal maps are greater than 35. Her permanent pacemaker will remain in DDD mode with a minimum atrial rate of 80 and max of 220 with a sensitivity of 10. We will continue with her daily Lasix dose at 0.5 mg per kg. And we will DC her chest tube today due to minimal output the past 24 hours. Her art line will also be DC'd as well today, as we no longer need to be monitoring her arterial blood gases. Respiratory, we will continue her pulse oximetry with goal saturations greater than 92%. Continue CPT every 6 hours for that right upper lung atelectasis until it has resolved, and we will be getting chest x-rays daily. FENGI, we will continue IV fluids of D10 0.5 half normal saline at 14 mL per hour. We will advance her continuous NG feeds of NeoSure 24 kcal from 5 mL an hour to 10 mL an hour this morning. If the patient tolerates this advancement, we will increase to 15 mL this afternoon and continue to advance by 5 cc's per hour every 6 hours. After she has reached 15 mLs on her feeds, we can turn her IV fluids off. HB's goal feeds are 21 mLs per hour. While the patient is on IV fluids, we will continue to get daily BMPs to ensure her electrolytes are stable. We will continue to replete cardioprotective electrolytes, PRN, for magnesium greater than 2, potassium greater than 3.5, and ICAL greater than 1.2. Speech is following this patient and we'll see her again after she has reached full feeds to determine whether this patient can attempt to PO feed or if we will need to evaluate her for a G-tube. The patient will get weighed twice weekly. Hematology, due to the patient's history of thrombocytopenia, anemia, neutropenia, we will continue getting CBCs every Monday. She is being followed by PEDS hemonc. Genetics, the patient's mother has a history of Sjogren's syndrome and the patient has SSA positive and SSB negative serologies. Her microarray on 4-4 was normal. Her newborn screen was positive for possible hemoglobin C trait. Her most recent newborn screen on 4/24 showed low fetal hemoglobin, which is most likely related to transfusions. We will get another SSA, SSB titer on 6/28 and will continue to get them monthly. Lines, we will DC her art line today. We will DC her PIC line once the patient has been stable for 7 days. Psychosocial, the patient's family has been updated daily, either in person or by phone. And DISPO, the patient will remain in the PICU until discharge per cardiology's request. She must remain cardiovascularly stable with no arrhythmias for 14 days post-op. From a GI standpoint, the patient will be evaluated by speech and may require G2 placement, which will extend her PICU stay.